Addiction is such a complex, multifaceted disease of the brain that is very difficult for those who are affected by it to understand, treat, and maintain. When a loved one is struggling with substance use disorder, it can feel especially confusing, overwhelming, frustrating, and hopeless. A major problem in the treatment of addiction today is that most treatment programs operate in a way that only focuses on the addicted individual themselves and neglects to involve or care for concerned families and struggling loved ones. Studies show that for every individual struggling with substance use disorder, 5 significant others are negatively impacted by their disorder. Think about it in your own experience. When was the last time you met somebody with absolutely no personal connection to addiction? The norm is that people can relate to addiction through their parent, child, sibling, relative, spouse, friend who struggles with substance use disorder. This statistic reinforces the common referral of addiction as a family disease, yet very little is done that supports the family. Today, I hope to expand your understanding of addiction by sharing some evidence-based practices and strategies that have been proven to help people recover, as well as share some misconceptions or myths about what effective addiction treatment looks like so that you can best support not only your struggling loved one, but equally as important, yourself. Um, One fundamental understanding of addiction, effective addiction treatment, is that no single treatment approach is appropriate for everybody. Um, a person-centered approach to treatment that matches an addicted individual's particular needs is critical to their recovery success. It is also important to understand that addiction is disease that affects an individual on a biological, psychological, social, and spiritual level. Effective treatment addresses all areas, not just an individual's substance use. As a matter of fact, many individuals with a substance use disorder also have a diagnosable mental health disorder, which is what we refer to as a co-occurring disorder. Um, and this co-occurring disorder constitutes about 10 million Americans in any given year. When treating individuals with co-occurring disorders, we find that an integrated model of care is the most effective, which means that the same team of professionals treats mental health and substance use disorder symptoms concurrently, so at the same time. One of the biggest roadblocks that we face when treating addicted individuals, especially those suffering from co-occurring disorders, is that oftentimes clients do not initially accept abstinence as a personal goal. Um, the way that substances affect the brain and the sense of reward they bring the user simply cannot compare to anything else, making abstinence very difficult. This phenomenon can be explained through understanding immediate versus delay reward circuitry. So, immediate rewards, such as the high that one reaches when using substances, tend to be much more salient, while delayed or potential future rewards lose value. This is known as delayed discounting. There is an evidence-based approach derived from the concept of operant conditioning known as contingency management, which has been proven to help individuals, especially those early in recovery, stay engaged, connected to services, um, and contingency management operates by providing rewards and positive reinforcements contingent on an individual's behavior, and withholding rewards for negative behaviors. It's not based on punishment, it's based on positive reinforcement and withholding. So, for example, if a client submits a urine screening that is negative, they will receive a prize or a voucher. If a client's drug test turns up positive, they do not receive a reward. Contingency management helps people make health promoting changes in their lives that would otherwise be very difficult due to the impacts of substances on the brain. Contingency management holds people accountable for meeting recovery goals, emphasizes one's recovery capital, keeps people in treatment long enough to reap the benefits of sober living, and has been proven to have lasting abstinence effects even after treatment. Another evidence-based approach that has been proven to help people, especially those who do not align with abstinence as their goal, is harm reduction. So harm reduction deals with the reality of substance use disorder. It acknowledges that some ways of using drugs are objectively safer than others, and harm reduction aims to mitigate the risks associated with using drugs by meeting people where they're at. The goal of harm reduction is to keep people alive today so that they may choose abstinence tomorrow. Some examples of harm reduction practices include syringe service programs, safe use sites, distribution of naloxone, housing first programs, decriminalization, and medically assisted treatment. Which brings me to my next topic. Medications are an important element of treatment for many patients, especially when combined with counseling and other evidence-based therapies such as CBT, motivational interviewing, and group therapy. Medically assisted treatment has been proven effective in helping addicted individuals stabilize their lives and reduce their illicit drug use. A common misconception regarding medically assisted treatment is that people are essentially just trading out one addiction for another. And a misconception regarding harm reduction is that harm reduction is enabling drug use. I find that these misconceptions both reflect a moral model of addiction as opposed to a medical one. Brain biology supports medically assisted treatment, and as substance use disorder biologically alters the brain circuits involved in reward, stress, and critical thinking. Medically assisted treatment works to repair the brain's chemistry, reduce cravings and withdrawal symptoms, and provides the prefrontal cortex the ability to recover its function. Medically assisted treatment creates controlled receptor activation instead of perpetuating the rapid intoxication to withdrawal cycle that essentially drives addictive behaviors. And on the topic of harm reduction does not make drug use more appealing, but it reduces its lethality. Take seatbelts, for example. We wouldn't say that seatbelts enable reckless driving, but they provide a buffer in case of an accident. Harm reduction strategies work similarly. They're designed to interrupt the most dangerous potential outcomes. Reducing lethality is not the same as reinforcing behavior, and this distinction is critical in understanding how harm reduction creates the stability needed for change. Framing harm reduction as enabling is a dangerous belief to hold because without harm reduction intervention, people could very well lose their life before they even have a chance to enter treatment. Let's see. A lot of people, including myself, before learning otherwise, tend to think that addicted individuals must voluntarily enter treatment for it to be effective. This is not the case. In fact, sanctions and enticements from the workplace, the criminal justice system, and family can notably increase treatment entry, treatment retention rates, and overall success of substance use disorder treatment. Another common misconception regarding substance use disorder treatment is that detoxification alone significantly reduces chronic substance abuse. While medically supervised detox is necessary to safely manage not only uncomfortable but potentially life-threatening withdrawal symptoms, detox is only the first stage of treatment, and in most cases, does not help addicted individuals achieve lasting abstinence. It's been proven that the best outcomes of treatment require that most addicted individuals stay involved in treatment for at least 3 months under continual monitoring and modification to appropriately adapt to the patient's evolving needs and goals. People tend to think that addicted individuals need to hit rock bottom in order to change their ways. I don't agree with this notion, as I believe family and significant social supports should be a protective factor instead of a risk factor. Um, Al-Anon and other interventions support detachment as a way to avoid enabling negative behaviors and personify the consequences of drug use. This method has been proven to be effective 23% of the time, while positive reinforcement, open communication, and increased family involvement tends to be effective 64% of the time. So um, almost 3 times more effective than the typical Al-Anon detachment. It is really important that families and significant others understand that relapse is a part of the disease of addiction. Open communication and involvement from existing supports can significantly reduce the negative impacts of relapse. Um, when addicted individuals return to use, it's common for them to feel as if they have messed everything up, they're morally wrong, and they're back at square one. This is known as the abstinence violation effect. Um, if these feelings are met with confrontation, shame, guilt, punishment, it's very likely that the addicted individual will just throw their hands up in the air and say, "What's the point? I've disappointed everybody, including myself. I might as well just get high again." Obviously, perpetuating their use. Um, However, when relapse is met with understanding, acceptance, communication, and a plan, the addicted individual bounces back faster, more supported, and better equipped to cope with their disease. Um, so, to diminish the absence violation effect, it is critical that relapse is framed as a learning opportunity rather than a moral failing in order to prevent recurrence.